Thank you, Vipin. Thanks. So what I'm going to do is show you some practical examples of the potential value of both the flow measurements with TTFM and also something that we increasingly use is ultrasound assessment, which comes as part of this package. My main conflict of interest, as I said, is that I have had research funding from Medistim, I've had speaking and travelling fees, and I act as an advisor to the company. So be cautious about everything you hear me say. This is a paper led by Mario Gaudino and a number of experts with a consensus statement on the use of intraoperative transit time flow measurements during CABG. And it concluded, in conclusion, although TTFM use may increase the cost and duration of the procedure and requires a learning curve, its cost-benefit ratio seems largely favourable in view of the potential clinical consequences of graft dysfunction. These consensus statements will help to standardise the use of TTFM in clinical practice and provide guidance in clinical decision-making. And part of this follows on from a prospective study we did that was funded by Medistim, the Request Registry. This was looking at 1,000 patients prospectively, done in different centres, 7 centres, and one of the authors is Greg Trachiotis and John Puskas, Teresa Kieser, who's in the audience. And we concluded from this surgical changes related to the aorta, conduits, coronary targets, and anastomosis were made in 25% of patients. This was associated with low operative mortality and low major morbidity. TTFM measurement and high-frequency ultrasound may improve the quality, safety, and efficacy of coronary bypass procedures and should be considered as a routine procedural aspect. But what I want to talk about over the next 10 or 12 minutes is what you do when it all goes wrong. And the one thing you learn as you start using this technology is that most of the abnormalities you detect in the operating room, when there's still a chance to fix it before the patient leaves the operating room, most of these are actually silent. You do not normally see changes in hemodynamics. You do not, even using TOE, see changes in echo function. You often will not see a change in the ECG. So it's an important learning point is that what this technology does is allow you to pick up things that you otherwise wouldn't know you have a problem. So here's case 1. This is a right internal mammary artery to the intermediate coronary. You see the flow is -1, pulsatility index of almost 70. So there's no question this is a graft that needs revision. And when we imaged the anastomosis with ultrasound to see if we could work out specifically why there was a problem with flow, you can see that the anastomosis is actually anatomically patent, but there's no flow in TTFM. And then on further visual inspection of this graft, it became more obvious there was a bit of a twist at the heel. So this is a graft was then revised. You can now see the flow 52 mils per minute, pulsatility index 1.5. But this twisted heel of the RIMA at the time was silent. And the learning point from this is that anatomically you may have a patent anastomosis on ultrasound, but still with no flow in the graft. So you have to think, where is the problem? Here's case 2. This is Lima to LAD. And I'm sorry, the scale's not particularly good, but it shows a flow of 17 mils per minute and a pulsatility index of 1. Now, we've got a number of experts in this room. So which of you who routinely use TTFM would say, I'm going to revise this graft? Anyone?
We need more information.
Okay, but so what would you do?
Well, I'd like to see the runoff. I'd like to see the size of the LAD.
Okay, right. I don't have all of that information today.
Blood pressure.
Yeah, well, I'll come back to that in a subsequent example. So anyway, what we did in this case, so we generally say a flow of greater than 15 mils in a Lima to LAD is acceptable. It's not super, but it's acceptable. But when you have a very low pulsatility index, it reassures you that you probably think things are okay. But when we image this with ultrasound, you can see that there is a stenotic narrowing of the insertion of the Lima to the LAD. And then this graph was obviously revised. Now the flow was 32 mils per minute, and you can now see a much more widely patent anastomosis. So this was actually a purse string effect, but again, it was silent to the clinician. And if you hadn't imaged and used ultrasound, we would have missed this. And the lesson here is ultrasound can still identify anastomotic problems, even with apparently acceptable flow and pulsatility index. Here's case 3, another Lima to the LAD, and again a very obvious problem, a flow of 5 mils per minute, pulsatility index of 6.3. And when we imaged this anastomosis with ultrasound, you can see that the toe of the anastomosis is blocked, but there is still some retrograde systolic flow. And again, after revision of this graph, a very significant increase in flow and improvement in pulsatility index. So in this case, the toe of the anastomosis was blocked, but again at the time it was silent, and if it hadn't been imaged, this would have been missed. This is case 4, and this is what happened in a patient with a localized endarterectomy of the posterior wall of a diffusely diseased LAD. And you can see with the red arrows that this LAD is diseased in multiple places. And the bit with the circle around it is where we decided to open the artery at this point and do our anastomosis. And this, because there was a heavy calcification on the posterior wall, we did a localized endarterectomy to give us a wider anastomosis. When prior to protein administration we measured flows here, we had 25 mils per minute in the Lima to the LAD post-endarterectomy and a low PI, so we were pretty happy with this. But when we did high-frequency ultrasound imaging, we could see that although the Lima to LAD anastomosis was widely patent, there was a flap on the posterior wall. But the question is, did that affect flow? Now, anyone who would accept this and just give protamine and not revise this? So nobody, except me. I thought this is unlikely to be functionally relevant. So we did give protamine, and it was followed pretty quickly by a significant reduction in flow and increase in the pulsatility index. And when we imaged this again, we could see that again the anastomosis was widely patent, but we could still see the flap on the posterior wall. But because there had been a significant reduction in flow, I did revise this graph. You can now see the intimal flap that we removed from the posterior wall. And then post-revision of this, we now had much better flow, 35 mils per minute. And you can see with ultrasound imaging a widely patent anastomosis. And in retrospect, I kind of was really surprised at this. I was surprised that that piece of intimal flap would make such a difference to flow. But I learned from it because I had been pretty confident leaving it would not have caused a major problem in this anastomosis. So next time I see it again, I will revise it. This is a case of one of my colleagues. He performed a saphenous vein to the obtuse marginal and had a flow of 8 mils per minute and a PI of 5.1. So he revised this graph 3 times and couldn't get the number to improve. Now, he didn't know and wasn't aware of how to use the ultrasound imaging, so he didn't use it. But what he did do was take the patient to the cath lab, where the cardiologist did a repeat angiogram, and they found actually that the graph was patent, but there was complete spasm in the native coronary circulation, and there was no further intervention in this patient. This is another case of mine, and this will follow on a bit from what David Glenier said about the importance of competitive flow. So this was a 48-year-old patient with a non-STEMI, occluded right coronary and circumflex and an LAD stenosis. And the LAD stenosis, to me, angiographically didn't look particularly impressive, but on FFR testing, it fell to 0.7 on vasodilation. So it was considered to be functionally important. So in this case, I cannot remember why this patient was done on pump now, but the flow on pump was 36, I'm sorry, after coming off bypass, the flow was 36 mils per minute with a PI of 1.0. So acceptable figures. And if you look at the trace, you can see is this very ragged appearance, which we call swordfish appearance. And that usually indicates there's a bit of spasm in your conduit. However, what then happened was on the end of cardiopulmonary bypass and towards the end of the operation, when we rechecked this graft, the flow was now 4 mils per minute with a pulsatility index of 18.7. So David Gleaner, what would you do here? You would redo the graft. Yeah. Would anyone not redo this graft?
I would snare the proximal LAD.
Okay. So what we did initially when we saw this was we imaged the anastomosis of the lima to the LAD, and you can see that it's completely normal, widely patent. And then we imaged the conduit, and we couldn't find any problem with the conduit. So we did not revise this graft. So given this appearance of that anastomosis, and you've imaged and there's not a problem within the conduit, would you still have revised that, David?
I think so.
Sam?
Probably.
Tor? Yeah? Greg?
Yes.
Well, maybe we got it wrong, but I didn't revise this graft, and this patient post-operative recovery was absolutely unremarkable. But certainly, had it not been for the imaging, then I would have revised the graft as well. But I couldn't persuade myself that there was a problem with the anastomosis.
Did you wait and do other maneuvers in the OR?
Correct, yeah, you do, and then we did it, before the chest was closed. But rightly or wrongly, that widely patent anastomosis, I did not think by redoing it, I was going to get it any better than that. So here's another example of native vessel competitive flow. So here's a RIMA to the LAD. Flow is 24 mils per minute, PI of 0.9, and there's a proximal elastic sling on initially when we measure this flow. As soon as we release this elastic sling, you can see that the flow drops pretty dramatically. And then when we reapply this elastic sling proximal to the anastomosis, we see a significant increase in flow again. And again, when we image this anastomosis, widely patent on ultrasound, so again, we accepted this as being competitive flow, but it does still make you slightly uncomfortable to see such a reduction in flow. And here's what can happen when you add other conduits. So here, this will be my final case, I think, just for the sake of time. So this is a case of a RIMA to LAD with a flow of 140 mils per minute, PI of 1.3, so very acceptable. And here is a RIMA to LAD flow after we've then done a graft to the OM with a lima and a saphenous vein to the PDA. And now you can see there's pretty dramatic reduction in that RIMA flow. And that's partly because the lima itself has a flow of 33 mils per minute, and the saphenous vein to the PDA, which was not a particularly good vessel with just 11 mils per minute, but an acceptable PI. And this, again, is what I said, this is what can happen in a case when you have spasm in a conduit. You get this very appearance of this swordfish tray, a very jagged appearance. Let me ask this time, Greg, what would you do in a situation like this?
What type of a conduit was it, David?
So this is a RIMA to the obtuse marginal. You can just see it at the bottom of the graph.
Yeah, so I would double check the way the graft is lined
Yeah.
to make sure that there's no tension, and I'd also make sure that the blood pressure was adequate, and then maybe check the flow at different areas along the RIMA first before I did anything, and then I would probably ultrasound it as well.
Yeah. Anyone do anything differently?
Check the EKG cables, because you can get that pattern with bad EKG signal.
It's unusual to see it like that, even with EKG cables in my experience. What we did here was we waited 10 minutes, did something else, came back, and you can see a totally different flow trace. So on that point, I do have other cases, but on that point I'm going to stop so that there's time for the other speakers. So I'd like to thank Medistim for supporting this symposium, and you, the audience, for your attention. Thank you.